Neuro Assessment. The Glasgow Coma Scale is based on a 15-point scale for estimating and categorizing the outcomes of brain injury on the basis of overall social capability or dependence on others. The test measures the motor response, verbal response, and eye-opening response. Peripheral Stimulus. This is a test to check for withdrawing. For a good grip, use a pencil or pen with flat sides. Place pencil sideways over nail close to the cuticle. This technique will cause bruising over time, so vary the assessments on all appropriate fingers and toes. Sternal Rub. Sternal rub is not like scrubbing a washboard, but like grinding a pail with a mortar and a pestle. This is an example of central stimulus. This can cause bruising or soreness, so don't use it exclusively. Trapezius Squeeze. This is an excellent way to get a response. The trapezius is a flat triangular muscle that covers the shoulders like a scarf, extending from the back of the neck to the shoulders. Grab the trapezius muscle, not just the skin, with your thumb and 2 fingers. Pinch 1 to 2 inches and twist. Supraorbital Pressure. Now avoid if facial fractures are suspected. Feel the orbital rim a little bit under the eyebrow. You'll feel a notch in the center. Push it hard. You should feel an instant headache. That's because a nerve lies in that little groove. Mandibular Pressure. Using your index and middle fingers, push up and inward at the angle of the patient's jaw. Avoid if facial or jaw fractures are suspected. Shake and inflict pain if not awake. Pressure on the nail bed may not elicit the same response as a trapezius pinch or supraorbital pressure and may initiate a spinal reflex response. Any response to any of these stimulants is more likely the brain is responding rather than a spinal or reflex response. If you look at the first one on A, this is a unilateral fixed dilated pupil. Pressure is on cranial nerve 3. For B, pinpoint pupils could result in brainstem hemorrhage. On C, unilateral small pupil lentosis, Horner syndrome with sympathetic and parasympathetic dysfunction. On D, failure of the eyes to look downward and inward. Left eye is normal. This is cranial 4 palsy. And then E, bilateral fixed dilated pupils, usually due to a herniation. Extraocular movement, EOM, are checked in awake patients only. So if a patient is in a coma, you cannot check EOMs. This is known as the 6 cardinal directions of gaze, used to test the function of the eye muscles together with the nerves that supply them. The number indicate the cranial nerve being tested by the particular eye movement. So 4-eyed cross-eyed is cranial nerve 4. Cranial nerve 6 is out to the side, means everything else is cranial nerve 3. Doll's eyes, Oculocephalic Reflex, OCRs. OCRs is often called doll's eyes, measured in unconscious patients only, and is normally recorded as present or absent. Can you check OCRs in an awake patient? No, that would be EOM. To check for doll's eyes, turn the head side to side. The normal response is for the eyes to go in the opposite side. Doll's eyes present. Abnormal responses are recorded doll's eyes absent. If the eyes move in the same direction as the head is turned and go no further than midline, then this is abnormal. Doll's eyes impaired. Never test if there is a question about cervical or vertebral injuries. Must have an intact tympanic membrane to do this test, also known as ice-water caloric test or cold calorics. It is more powerful in eliciting eye movement. An intact tympanic membrane is essential in order for the test to be accurate. The head of the bed is elevated to about 30 degrees. The physician slowly injects ice water until nystagmus, eye deviation, occurs, or at least 200 mL of ice water has been used. In the unconscious patient, the eyes move slowly toward the irrigated ear and remain there 2 to 3 minutes. This is one of the tests used for brain death criteria. If no response, then check other reflexes to determine brain death. Abnormal flexion, also known as decorticate posturing. Look at the flexion of the arms, the wrists, and fingers, the internal rotation with plantar flexion of lower extremities, flexion to the core. As the arms come out, abnormal extension, also known as decerebrate posturing. The arms extend, adduct, and hyperpronate. The legs are stiffly extended and the feet are flexed in a plantar position. Now we see the patient go into flaccid. When this happens, this is brainstem compromise and lesion of the midbrain or pons, leading to death. If you look here, nystagmus is a term used to describe fast, uncontrolled movements of the eyes that may be side-to-side, horizontal stagmus, up and down, which is vertical stagmus, or rotary, which is called rotary or torsional nystagmus. Depending on the cause, these movements may be in both eyes or just one. The term dancing eyes has been used to describe nystagmus. If you look at this particular patient, we're looking at the incomplete reaction to the eye. An oval eye, like you see here, will let you know if cranial nerve 3 is being compressed. A hippus is a spasm of the iris resulting in exaggerated rhythmic contractions and dilations of the pupils that are not consonant with accommodation and light. Hippus may also be associated with systemic disorders such as multiple sclerosis, neurosyphilis, and myasthenia gravis. Graphesthesia tests the individual's ability to use sensory input to identify a number or letter drawn onto a patient's hand while visually occluded. This is testing a two-point discrimination. An example of the density of touch receptors is to lightly touch the skin over the vertebral column. Because touch receptors are relatively sparse in this area, the probes must be far apart before they can be received as separate stimuli. Compare this to how closely the probes can be placed on the sole of a foot and still be perceived as separate. This is because touch receptors are distributed more densely on the sole of the foot. Heel-to-Shin Test. The Heel-to-Shin Test is a measure of coordination and may be abnormal if there is a loss of motor strength, proprioception, or cerebellar lesion. If motor and sensory systems are intact, an abnormal asymmetric heel-to-shin test is highly suggestive of an ipsilateral cerebellar lesion. The patellar reflex is a type of deep tendon reflex which occurs when an area just below the patella, also known as the kneecap, is struck. In healthy individuals, when the right spot is tapped, this of course causes the leg to kick out almost instantaneously. This reflex is what is known as monosynaptic reflex because only one synapse needs to be crossed to complete the circuit which triggers the reflex. When the area below the kneecap is hit with a reflex hammer, it hits the patellar tendon, which causes a quadricep muscle in the thigh to contract, leading the leg to kick out. This involuntary response does not involve the brain, only the spinal cord, and while it feels instantaneous to the observer, around 50 milliseconds are actually involved in this response time. Biceps and brachioradialis reflexes are mediated by spinal nerves C5 and C6 nerve roots. The triceps reflex is mediated by the spinal nerves C6 and C7 nerve roots, predominantly by C7. Achilles Reflex, a plantar flexion extension of the foot resulting from contraction of calf muscles following a sharp blow to the Achilles tendon. The variations and their significance correspond closely to those of a knee jerk. It is exaggerated in upper motor neuron disease and diminished or absent in lower motor neuron disease. Superficial abdominal reflexes. Stroke the abdomen lightly on each side in the inward direction above and below the umbilicus. Note the contraction of the abdominal muscles and deviation of the umbilicus towards the stimulus. Plantar reflex. Hard object to lateral surface starting at the heel and going over the ball of the foot ending beneath the great toe. Quick reminder, do not use an uncapped ink pen. You see the lines on the foot. Flexion of all toes. This is a normal response to a plantar stimulation. This is a Babinski sign, dorsiflexion of the great toe and fanning of the other toes. One other test that I'm going to include here are the Doppler ultrasound scanning, which measures blood flowing from the carotid arteries or the arteries at the base of the brain. This test assesses the risk of stroke. This painless technique shows different speeds of blood flow in different colors on a computer screen. It can also show blocked or reduced blood flow in the arteries of the neck that could cause a stroke. Additionally, it could show blood clots in leg veins that could break loose and block blood flow to the lungs. During a duplex Doppler ultrasound, a handheld instrument, transducer, is passed slightly over the skin above a blood vessel. The transducer sends and receives sound waves that are amplified through a microphone. The sound waves bounce off solid objects, including blood cells. The movement of blood cells causes a change in pitch of the reflected sound waves called the Doppler effect. If there is no blood flow, the pitch does not change. A computer processes the information from the reflected sound waves to provide graphs or pictures that represent the flow of blood through the blood vessels. These can be saved for future review or evaluation. There are 4 types of Doppler ultrasound, including continuous wave Doppler. This measures how continuous sound waves change in pitch as they encounter blood flow blockages or narrow blood vessels. This type of ultrasound can be done at a person's hospital bedside to provide a quick estimate of the damage or disease. Duplex Doppler. This produces a picture of the blood vessel and the organs that surround it. A computer converts the Doppler sounds into a graph that provides information about the speed and direction of blood flow through the blood vessels being examined. Color Doppler. In this procedure, a computer converts the Doppler sounds into colors that are overlaid on the image of a blood vessel. The colors represent the speed and direction of the flow through the vessel. Now, if you look at this picture, the top shows a transcranial Doppler of a normal artery. The bottom shows a severely stenosed internal carotid artery.